Hi, welcome. This is chapter 4. This is Barbara Garcia. Back to you a little bit about cellular injury, aging, and death. If you forget a little bit about the functions of our cells and our ion concentrations in and outside the cell, a little bit about genetics, meiosis, mitosis, it's really important to review chapter 3. But chapter 4 talks a little bit about cell injury, right? So cell injury can be either reversible or not reversible, right? So one of the methods of reversible cell injury are going to include hydropic swellings, right? Swelling due to an accumulation of water. And why might the water accumulate, right? So it's often one of the first manifestations of this form of reversible cell injury, because the sodium potassium pump has failed, and basically the sodium that's inside of the cell is in excess. And if you remember, the way that it works is osmosis. Since the sodium can't leave the cell unless it's pumped out, right, the water is going to cross inside the cell and is actually going to swell the cell, right? So in other words, sodium is higher on the inside than it's supposed to be, and so you're going to have an influx of water due to that via osmosis, right? So another way that can happen is also by a loss of energy. So a loss of energy, right, is going to kind of back up the system, right? So any injury that results in that will also result in swelling. All right, so you can see here normal lining of a nice cuboidal epithelium here, probably the kidney, and then you can see here the excessively large enlarged cells that can also actually be damaged due to that. You can see the accumulations of fluid in these white areas, right? So large pale cytoplasm, dilated endoplasmic reticulum, and swollen mitochondria are the characteristics of hydropic swelling, right? So you're going to see hydropic swelling causes a lot of cells in the organs to increase in size. Then obviously, by obvious reasons, if you increase the cells of the organ is going to become larger. And so you're going to see the word megaly, like splenomegaly, hepatomegaly. So you could think of splenomegaly and hepatomegaly in two very common disorders. Obviously, cirrhosis of the liver is going to create hepatomegaly. Okay, so obviously that's damage, and it's mostly that type of damage is obviously mostly due to alcohol or Tylenol abuse. So overuse of Tylenol can actually also lead to cirrhosis and hepatomegaly. And then you'll see that it's actually kind of bumpy. If you've heard of this genetic disorder, so the etiology for this disease would be genetic, right? Called hereditary spherocytosis, where the red blood cells, instead of being like dumbbell shaped, they're actually, because there's a genetic defect in the proteins that create the cytoskeleton of red blood cells, the red blood cells actually don't take on that shape. They actually take on a enlarged round shape, spherocytes, right? And so hereditary spherocytosis is going to have a major problem in the spleen, because the spleen has these very small little tunnels, right? Very small capillaries through which the red blood cells kind of supposed to kind of wiggle its way through there. So in people with hereditary spherocytosis, you're going to not really be able to do that because the cells are swollen and round, so they can't wiggle their way through these very tiny capillaries. So it creates a problem in the spleen, and you're going to see the lack of delivery of glucose and lack of oxygen, and all of that is going to stop ATP production, and is going to create a problem, and it's going to cause splenomegaly. The spleen enlarges, and if the spleen can't be fixed, the genetic disorder can't be fixed. So the spleen's going to have to go. Okay, so we can't change the structure of the spleen, and we can't change the genetic defect, so we're going to have to remove the spleen. So a splenectomy is going to be performed, and actually that's pretty curative, right? That's usually going to stop the main disease manifestation of hereditary spherocytosis. That's kind of an interesting little thing there. All right, so intracellular accumulation. So I don't know if you remember, right, we have regular things that are supposed to be inside our cells. We call those inclusions. You might have pigments that are included inside of certain cells, and especially skin cells. There's going to be glycogen is also an inclusion that you might see sort of floating inside the cell. Fat droplets or fat bubbles, like in adipose tissue, the fat droplet is really big. In others, they might be much smaller than that, but these are normal. Now, excessive accumulations of certain pigments or other factors can lead to toxicity, and then the immune response to try to, you know, kill that cell, and then taking up space. So that can also cause some damage to the cell. So accumulations of excessive amounts of normal intracellular substances can also do that. So you're going to see here in the picture, there's a picture here in figure 4.2 in page 59, that you can see like a normal cell versus a fatty liver, right? A fatty liver cell has lots of accumulations of fat droplets, right? So those fat droplets are way more than they should be. So you'll see that the one that is the normal cell does have some. Then protein mutation, right? So remember, proteins are created obviously by transcription, and then made into proteins by translation, right? So from the DNA. So if there is a defect down the line, you're going to have accumulations of the reactants that make the products, right? So you might have an accumulation of proteins, and that could also cause a problem, right? And then, so you can see here in that figure 4.2, again, you have an enzyme that catalyzes a reaction. There are many enzymes throughout our body, but one of the many places where an extremely high concentration of enzymes is located in the lysosomes, right? In a lysosome, you have all of these digestive enzymes, and if there's one enzyme that doesn't function properly, you're gonna have an accumulation of material, right? That can be very toxic. If you see Niemann-Pick disease, and some of our other lysosomal storage diseases that are due to a lack of a particular enzyme, they are gonna have like Tay-Sachs disease is another example. These are lysosomal storage diseases because there's an enzyme that doesn't allow the proper breakdown of our macromolecules, and so you're going to have an accumulation of a product that normally could be broken down, right? And then indigestible materials, as you see in the last example. So those are all really important, right? So liver, right, chaperone proteins may be damaged, right? And if they're damaged, then the protein is going to not be able to function properly. So chaperone proteins limit protein damage. Chaperone proteins often help proteins refold into their correct shape. If they are not there, you're going to see that they're going to can create some protein damage. You can see the fatty liver example, right? So some protein damages. So ubiquitin is kind of a cool thing because it's right the pathway, right? The activation of the ubiquitin proteasome pathway is actually going to kind of break down and degrade these improperly folded or not folded proteins. And then one last thing that can happen is if there is a particular stressor, notice heat, UV, free radical injury. Remember, UV light can damage DNA. Okay, so anytime that you have, remember A, C, T, and G are right, the nucleic acids, right, that are going to, the nucleotides that are going to make up the nucleic acids of DNA. If you have two T's together, UV light causes a thymine dimer, which means the two thymines that are together, the two T's that are together, they form a bond that can't be broken. So you have to kind of excise that area and replant those nucleic acids. All right, and then free radical injuries. So remember, free radicals are substances or chemicals that have an odd number of electrons, and they're very damaging. So those are going to cause, you know, sometimes proteins to not be folded properly and so on. So ubiquitin proteasome pathway is kind of our last chance to get these things to degrade and break down the damaged proteins. And if not, one of the things we could do is activate caspases, which initiates the process of apoptosis, which means that cell's going to die. So I want you to realize that apoptosis is called programmed cell death because it is the way that our body knows how to deal with damaged proteins, damaged DNA, and that if nothing else can be done, right? So see, if the chaperones can fix it, that's great, but if they can't and the ubiquitin proteasome pathway is overwhelmed, we can actually cause the cell to undergo apoptosis and die. One of the ways we can also initiate that is like DNA polymerase. So if you remember DNA polymerase, that's the enzyme, right, that initiates transcription, right? And if DNA polymerase detects damaged DNA, it can also activate these caspases and undergo apoptosis, because we don't want damaged, you know, cells with damaged DNA to start undergoing mitosis and continuing to replicate. All right, so some of our cellular adaptations. So normal cells, this might be a depiction of a normal cell. And so these are really, really, really important words. Atrophy is decreased cell size. Hypertrophy is increased cell size. Hyperplasia is increased cell number. All these things are very different. Okay, so atrophy. Let's say that you broke your leg, and at the end of the summer, right? Let's say that you broke your leg at the beginning of summer. By the end of summer, your cast comes off and one leg is smaller than the other. Why might one leg be smaller than the other if you've been casted for 4 months, 3 months, right? Because obviously you are not utilized that leg, and the muscles the cells have decreased in size. So then you're going to have to work harder to get that back. In other words, we call that, return to either normal size or maybe increase in size. So increase in cell proteins, like contractile proteins, can increase the size of cells. That's called hypertrophy. I want you to realize that your muscle cells undergo hypertrophy. They do not undergo hyperplasia. Hyperplasia, in many respects, hyperplasia can be much more associated with cancer than it can with normal processes. So normal processes, you don't have, hyperplasia of your neurons. The neurons don't undergo mitosis, pretty much at all, if at all. Your heart muscle does not undergo hyperplasia. It undergoes hypertrophy. It gets larger, just like your skeletal muscle cells do. So hyperplasia is reserved for only certain things and certain adaptations in our body. But definitely cancer is considered a hyperplasia, right? When you have a tumor, right? And so before things become hyperplastic, you might see dysplasia. Or metaplasia, right? So metaplasia, so for example, a smoker is constantly inhaling certain toxic chemicals into their lungs, and their lungs have to protect themselves, right? So your cilia die because the toxins kill the movement of the cilia, and then you start coughing. So it's the typical hacker's cough that you see in smokers. Then the lining, remember, which in your respiratory epithelia is pseudostratified ciliated columnar epithelium, starts to undergo metaplasia. It changes. It changes from pseudostratified into a stratified squamous. Stratified squamous is protective, just like your skin and your lining of your vagina and the lining of your mouth. All of these things are protective. They have many layers to protect against friction. So metaplasia means that the DNA has changed. Can it be changed back? Yes. Remember, there's upregulation and downregulation. So you upregulated something and downregulated something else. So can you flip that? You can probably flip that, but sometimes you've done enough damage that you can't. Okay. Dysplasia, very commonly seen in people who have cervical changes, right? So in your cervix, you might see, or might, it might come back that you have cervical dysplasia, which means that the cell shape has changed. The nuclei is often going to be larger. The cell is different. And so this could indicate certain changes going on in the DNA, which could be cancer. So dysplasia is something that needs to be monitored. It doesn't need to, you don't have to freak out, but it just needs to be monitored. Right? So again, atrophy, right? Some general causes for atrophy is disuse. So the entire summer you spent without using your leg because it was in a cast. So disuse is going to cause atrophy. Denervation. So people who have lost the ability to walk due to spinal cord injury undergo denervation atrophy. So since your motor neurons are not communicating with a muscle, it is going to create a situation in which it atrophies. So you'll see people with their legs and limbs that may be very tiny in comparison to what they used to be when this person was ambulatory, right? Ischemia, so lack of blood supply, right? Nutrient starvation, interruption of endocrine signals, or persistent cell injury. All of these things can cause atrophy. All right, so biochemical pathways like the ubiquitin proteasome pathway and it constantly breaking down proteins and lysosomes also can create atrophy, right? Hypertrophy, right? So increased cellular protein content, right? So remember that is enlarged. So for example, you can have an enlarged heart for one of two reasons: either because you're an athlete and you're just the bomb and you have an amazing cardiovascular system, you can have cardiomegaly, or somebody whose heart has to work up against a very high blood pressure or hypertension can also develop hypertrophy. Usually that hypertrophy is going to be unbalanced and it's going to lead to left-sided heart failure. All right, so you can see here, you have your normal, right? And then your hypertrophic heart. So this is your left ventricle, and this is a normal left ventricle. Oh, and then this is the right ventricle, normal right ventricle. Right? Hyperplasia, right? Increasing the cell number due to mitotic division, right? So for example, in the normal, right, you're going to see hormonal stimulation or physiological demand increasing the amount of cells that are going to be able to perform that function. All right, and then metaplasia, replacement of one cell type with another, right? Fully reversible when injurious stimulation is removed. Okay, so metaplasia can reverse. Remember when I told you about the smoking, it can be reversed. And then dysplasia, right? So abnormal variations in size, shape, and arrangement often represents adaptive effort, but that has not been able to be very good. So it's significant for cancer. So pre-neoplastic. So neoplasm is a new, right? Plastic usually means production of, so some new production of cells. All right, so I mentioned the word apoptosis, and necrosis is kind of the opposite of apoptosis. Those are two words you really need to be very comfortable with. Apoptosis, just to go back really quick, was programmed cell death. So this is a cell that has something within it that is erroneous, and there is an initiation of a cascade that is going to cause that to change, and that cell is going to undergo a certain involution, and it's going to die. So it's going to basically be consumed from the inside so that it does not create an inflammatory response. Necrosis, however, is kind of the opposite, where the cell swells or the cell is bursted, and now all of the contents of the inside of the cell are on the outside of the cell where they're not supposed to be. And so the immune system is called forth in order to kind of clean up the mess, right? So it initiates the immune response, right? So, you know, ischemia, lack of oxygen, right, or toxic injury, either one of those things can cause necrosis, right? Right, so hypertrophy and hyperplasia usually result from some sort of increased demand, whereas atrophy, right, decreased demand, right? So these are reversible, right, adaptive cellular responses, and these you might see cell rupture or spilling of contents into extracellular fluid and inflammation, right? So there's 4 types of tissue necrosis. The most common type is coagulative necrosis, right? It's a process that begins with ischemia, so lack of blood flow to the tissue. So when there's a lack of blood flow to the tissue, that means that there is no way for that cell to undergo any mechanisms to make to make ATP, and then eventually ends with degradation of the plasma membrane, and the cell basically dies. So you'll see that in most like muscle cells, and so on, right? So liquefactive necrosis is going to occur right with the dissolution of dead cells. It's basically the lysosomal enzymes in the lysosomes cause liquefaction. So basically the cells liquefy, right? So you might see an abscess, something that's filled with fluid, or a cyst, that as liquefactive necrosis. The brain undergoes liquefactive necrosis. So if there was a stroke, you'll see that brain tissue basically becomes fluidish. Okay. Fat necrosis, right? Death of adipose tissue, right? Usually this is a result of some sort of trauma or pancreatitis, and you might see chalky white area of tissue because remember, fat is usually a light color, light yellow or white. Then you're going to see caseous necrosis, and caseous necrosis is very common in lung damage like tuberculosis, right? And so it resembles clumpy cheese. As the name implies, if you look up the word caseous, that is going to mean cheesy, right? So which type of irreversible cell injury initiates an inflammatory response, right? So the one that creates an inflammatory response, right? Hydropic swelling, you know, is normal or reversible, not normal, but reversible. Intracellular accumulations as well. Apoptosis is not going to involve the inflammatory response, but necrosis will. Right, so 4 types of tissue necrosis. You can see that here: caseous necrosis and fat necrosis, and then liquefactive necrosis here in the brain. So this is gangrene, right? So gangrene is cellular death in a large area of tissue, usually from interruption of blood supply to a particular part of the body, right? So it's a form of coagulative necrosis, usually seen as black, dry, wrinkled tissue, right? And basically dead tissue, right? Demarcated from healthy tissue at a particular point. So you'll see healthy tissue receiving the proper blood flow, and then everything else beyond that being very dark in color. Oftentimes you might see that people have tips of their fingers or toes have dry gangrene, and sometimes they just fall off. Wet gangrene is a form of liquefactive necrosis, typically found in internal organs. Can be fatal. Gas gangrene is a type of gangrene that is as a result of the anaerobic bacterium Clostridium. And if you remember Clostridium, Clostridium is anaerobic, which means it is going to be, oxygen is toxic to this type of bacteria, right? And basically it forms a bunch of gas bubbles and damaged tissue and can be fatal. And the way we can try to combat gas gangrene is by attacking the Clostridium with oxygen. So like a hyperbaric chamber with 100% oxygen may be able to stop the gas gangrene from spreading. Apoptosis, like I mentioned before, it is programmed cell death, right? Occurs in response to an injury that does not directly kill the cell. You might see an, a triggering of intracellular cascades. Usually, the cell itself has mechanisms that are going to understand and know whether or not these mechanisms are going to be able to maintain a cell. If it is able to maintain the cell, then apoptosis is not going to occur. If it says this is something that we can't recover from, then it's going to cause cell death. Okay, not necessarily pathological. It could be, but it's not necessarily pathological. Very early in development, we have webbing between our fingers, and the webbing between our fingers is then going to create, right? We're not born with this webbing. We're going to actually have apoptosis kind of break away the webbing between our fingers, right? So it doesn't cause inflammation. It does not call forth the immune system. It is just basically going to break apart all of the lysosomes and just degrade the cell from the inside out. So the cell just sort of disappears, right? So two types of environmental or extrinsic signals may induce apoptosis. So withdrawal of survival signals, right, usually and normally suppress apoptotic pathways, like in cancer cells. So cancer is actually going to, once the cell realizes that there's a cancer signal, many of the times apoptosis is going to occur. Okay, so you might see here matrix proteins, that this is the way the cell is supposed to be. So this basically tells the cell, right, that this is a appropriately functioning cell. But in a cell that has the signals, right, the communication between the matrix proteins and so on have been lost, then this cell is no longer a cell that's properly functional, and it's going to undergo apoptosis. And again, it does not necessarily need to be pathological. It could be that the cell is old and needs to be replaced. All right, so the FAS ligand, right, binds to the cell and triggers the death cascade through the activation of death receptors. So that is the extracellular signal, that initiates apoptosis. So you can see FAS receptor with the FAS ligand, right, it activates the caspases, and you're going to have nuclear fragmentation and apoptosis and death. Right, so intrinsic pathways, right? Cell damage can actually, severe cell damage can cause one of our main proteins to be initiated, which is P53. The P53 pathway is basically, if you remember mitosis, going back to chapter 3, if you remember mitosis, and mitosis is going to be a part of the entire cell cycle, right? So the cell cycle is going to have interphase, and interphase has 3 parts, right? So interphase is going to have G1 phase, the S phase, the G2 phase, and then it's going to go into mitosis. This is the entire cell cycle. P53 is one of our main monitoring pathways, right? That is going to monitor whether or not there's severe cell damage. So P53 is going to be at that checkpoint right before the S phase. So we don't want to replicate DNA in a cell that has severe cell damage. So if there is severe cell damage, P53 will initiate the FAS ligand and the apoptosis pathway, right? So in main component is going to be the caspases that are going to be triggered. And so the DNA, so especially in things like DNA damage, the cell is going to be is going to initiate apoptosis and die, right? So necrosis occurs when injury is too severe. So like, let's say that you had a crush injury to your leg, you're going to have necrosis. So some of those indicators are pain, elevated serum enzyme levels, inflammation, fever, right? Increased white blood cells, malaise, and then loss of function. So these are all things that are going to indicate that, like a crush injury, for example, would be really, really severe. All right, so types of necrosis depend on tissue type. So the heart undergoes coagulative necrosis, the brain is liquefactive necrosis, the lung is caseous necrosis, and the pancreas is fat necrosis, and you absolutely need to know that. Right, so dry, wet, or gas gangrene, right, is a large area of necrosis. Wet and gas gangrene can be fatal very, very quickly. All right, so apoptosis is tidy and is not usually any type of inflammation is associated with it. It's basically just signaling the cascade system to initiate cell suicide. Right, so ischemia and hypoxic injury. So tissue hypoxia, right, which means lack of oxygen in the tissue, is most often caused by ischemia, right, which is lack of blood flow. Right, and so obviously it causes a power failure in the cell, because if you remember your Krebs cycle, your oxygen is the final electron acceptor. If oxygen is not there, because you're ischemic, means that the blood delivery is not there, then how is your tissue and your cells supposed to function? Right, so injure cells much faster than hypoxia alone. Okay, combination of this, and so basically that's what happens, by the way, when you have coronary artery disease and you have a myocardial infarction due to like accumulation of atherosclerotic plaque. Basically, it causes ischemia because it basically accumulates in the coronary arteries, right? And so then that causes your heart muscle to not receive sufficient oxygen. Your heart muscle is obviously dependent on a constant flow of oxygen. To accumulate, right, combination of disruption of oxygen supply and accumulation of metabolic wastes, right, basically is going to cause ischemic and hypoxic injury to the cell, and the cell's going to die. Right, so one of the things that happens when there's no oxygen is you're going to go to your anaerobic pathways, right? So if oxygen is not there to be the final electron acceptor of the Krebs cycle and the electron transport chain, then you're going to go into producing lactic acid through glycolysis, right, and anaerobic fermentation. And if you do that, then you're going to have a lactic acidosis. So then cellular proteins and enzymes become less functional because proteins work at a particular pH. Once you have lactic acid, now you're changing the pH, and you're no longer going to have the ability to maintain the proper function of those proteins and enzymes, right? And so ischemic injury is reversible to a point, but once the cell death is going to occur if things and functions are going to be critically damaged because of changes in pH, and so on. Right, so we have this ischemia reperfusion injury that can be caused due to a lack of blood flow, and then all of a sudden like a blood flow that comes after it, right? So you have calcium overload and formation of free radicals that can occur and then can increase inflammation. And so reperfusion injury following an ischemic episode results in further tissue damage due to, right, production of excessive lactate, excessive intracellular calcium, excess body fat and adipose tissue, or production of exotoxins. I'm going to let you go ahead and kind of go back for a few slides and see what the answer of that one is, okay? All right, so nutritional injury, right? Obviously, we require our macromolecules, fats, carbohydrates, proteins, and our vitamins that are derived from our, and our minerals that are also going to be required in order for cells to function. If the cells are not receiving adequate amounts of fats, carbs, proteins, their vitamins and minerals, then the cell can't function properly. So obviously nutritional injury is going to, right, cause cells to die if they're not receiving those, or to slow down their function, right? So poor intake of nutrition or altered absorption. So you're not absorbing it for whatever reason, it's not being broken down. So remember, going back to physiology, right? Remember that if you do not have the enzyme lactase, you cannot have breakdown of lactose, And if you don't have breakdown of lactose, you could be, decreasing the amount of glucose and galactose that's being absorbed by your cell. Okay, because you can't absorb it in the form of lactose, you have to absorb it in the form of glucose or galactose, which are monosaccharides, right? So an absorption is going to be altered in that sense, in that case. An impaired distribution by the circulatory system, or inefficient cellular uptake, right? So common causes of malnutrition: poverty, chronic alcoholism, acute and or chronic illness, self-imposed dietary restrictions, and malabsorption syndromes. So poverty, right? Things like lack of nutrients or appropriate concentrations, not concentrations, but balance of nutrients. So for example, I could give a child lots and lots and lots and lots of carbohydrates, but if I give him too many carbohydrates, is he going to be able to make proteins like, contractile proteins in his muscles? And is he going to be able to increase his muscles? No. So if he can't do that, then he's going to have a malnutrition due to imbalance, right? So you can give him all of the, rice that you want, but in order for him to be able to flourish, he's going to require both, not only your carbohydrate, but also protein requirements. Because if not, where does the body go to get proteins? It's going to go to get proteins in your muscles, because your muscles do have proteins. So you're going to see muscle wasting, and you're going to see liver become hepatomegaly, right? It's going to become enlarged because of that. And then chronic alcoholism in the same way, right? So some illnesses it's self-imposed dietary restrictions, like if there was a child that does not have an adequate of each one of their macronutrients, an adequate consumption of each one of them, and only has carbohydrates, for example, it's called kwashiorkor. Kwashiorkor is a type of malnutrition. But if you are completely not receiving any nutrients at all, whether it be self-imposed or due to poverty, we call that marasmus. So there's two types of malnutrition. Malnutrition due to an imbalance in the proper macronutrients called kwashiorkor. And most of the time it's because you have more carbohydrates than protein. But if you are completely not receiving any nutrients at all, it's called marasmus. So you'll see the little kids with the big bellies and the skinny arms, skinny legs, that's kwashiorkor. And then you see those that are skinny, and they're emaciated and have no bellies. These are undergoing marasmus, and an absolute diet, a diet that has very little nutrients in it at all. And you also can have malabsorption syndromes like celiac disease, right? Where the absorption is going to be affected. All right, so BMI, right? So nutritional excesses primarily result from excessive intake. So a BMI greater than 27 imposes a health risk. So up to a BMI of 27 has not been found to have any higher incidence of heart disease. So no BMI higher than up to 27 has been shown to have a higher incidence of heart disease. So most findings have found that anything above 27 pose a health risk. And then of course a BMI greater than 30 is going to be obesity, right? And then over 35 or 40, you're going to see morbid obesity. And so those two are going to really affect the function of your body and the ability for your body to adapt, and obviously going to create a great stressor on your body, especially your heart. And so it could definitely be detrimental. But even cancer, people who are obese have a higher risk of most cancers because of the obesity alone. All right, and I want you to remember that your BMI is going to be calculated as your kilograms in weight divided by your height in meters squared. okay? Height in meters squared. All right, so for example, I happen to weigh about 170, and I am 1.78 meters tall. If you calculate, my BMI should be about 24 or 25, right? And then infectious and immunological injury, like bacteria and viruses, can also injure cells, and right, in a variety of ways, but that really depends on its virulence, right? So its ability to cause disease. And then the added injury may occur indirectly by also triggering the immune system response, right? So you have lots of different cascades. If you remember the complement, and complement pathway is going to initiate, like, you know, your neutrophils to start with their perforins and start, you know, bursting apart cells, and so on, and your other components of your complement system. Chemical injury, right? Toxic chemicals or poisons can also cause cellular injury, both directly and by becoming metabolized into reactive chemicals by the body. So things like cigarette smoke is toxic. Right, so physical mechanical injury, like extremes in temperature or abrupt changes in atmospheric pressure, mechanical deformation, electricity, ionizing radiation, all these things are mechanical injuries that can happen. I mean, electricity, you can get hit by a bolt of lightning, especially in South Florida, right? That can cause, you know, DNA damage, free radical damage, and then those can cause necrosis, genetic mutations, and or apoptosis. Right, so radiation sickness. So if there is, you know, an increase in radiation, which is something that is, as unstable chemicals become more stable, they release radiation, and so some of the radiation sickness, cellular injury that you might see can lead to cerebral edema, esophagitis, myocarditis, kidney inflammation, sterility, dermatitis, bone marrow depression, and it can even go to leukopenia, anemia, or thrombocytopenia, bowel necrosis and ulceration and diarrhea, and pulmonary inflammation and fibrosis. All right, so accumulation of two factors, both cellular and molecular damage. So progressive decline in proliferation. So as you both decrease the amount of new cells and the reparative effort of new cells, you can slow down, right, the effectiveness or the ability for cells to do their job. So they are basically going to start to decline in their ability to do their jobs, right? So exposure to environmental factors can even initiate this faster, like sun damage on your skin, right? Breaks down the collagen faster than you can replace it. Right, so cellular basis of aging, right? So some of the responsible mechanisms might be DNA damage, reduced proliferative capacity of stem cells, and accumulation of metabolic damage, right? And so some of the theories include programmed senescence. So basically cells have basically a limited amount of times they can undergo mitosis. And then free radical is that there are free radicals that are created through our body, and they damage cells to the point where you have a decrease in cells and you have decrease in stem cells, and you basically are going to slow down the ability for you to repair new cells because due to less cells. All right, so the programmed senescence theory is basically that our cells have a limited number of times that they can replicate. So they have these basically non-coding components at the end of the chromosomes called telomeres. And as the cell replicates, the telomeres shorten, and eventually they get so short that you can no longer replicate this chromosome. So this is a very, very well-established theory that has been found to be quite correct in many, many studies. So this isn't like a guess. This is really a very well-established function of our chromosomes, right? So then obviously as we age, our physiological changes also are going to occur. So we have, functional reserve is going to be decreased, inability to adapt to an environmental demand, and so you're going to have slowed, right, ability to clot the blood, slowed ability to repair tissue, slowed ability to heal wounds, and so on. All right, so question 3, a patient who is 85 years old reports to a healthcare provider every year for a flu shot. This is an important preventive intervention because A, telomeres increase with age, immune and respiratory reserves decline with age, rigor mortis can lead to somatic death and aging, radiation sickness can make the flu and aging worse. So C and D, I'm gonna have you look those up to make sure that you understand that neither one of those are true. So we're gonna go with, and telomeres I just showed you, and so we're gonna go with B, immune and respiratory reserves decline with age. All right, so somatic death, basically, remember soma means body, so the death of the entire organism, right? Right, no inflammation or immunologic response necessarily occurs prior to death, right? Basically, the cessation of respirations and heartbeat are going to be what you find in a person who just has somatic death. Eventually, that everything just kind of stops, right? You might see stiffened muscles throughout the body after death, called rigor mortis. Then they become flaccid again. You might see lytic enzymes, and then brain death is proof of somatic death. All right, so that's chapter 4, and I'll come back and see you for another chapter.